welcome everyone. Members and guests, I've been having, I apologize, internet issues. I just moved and I'm trying to work on it, but hopefully George has very good connection. Um, anyway, everybody does hear us. Okay, we're good to go. So George is, let me give you a little background on Georgios Kotsakis. He's first received his dental degree at the University of Athens. And after graduation, he practiced there for several years and then came to the US, where he completed his residency in perio and MS in science at the University of Minnesota. And that's where he first got involved with peri-implantitis research. After that, he became involved in teaching at the University of Washington in Seattle, and then moved on to San Antonio. And George, I don't think you knew this, but I did my dental school training there in 1980. And then he's following me after San Antonio. He's getting closer to me. He's now teaching at Rutgers, currently assistant dean for clinical research, and he at the Rutgers School of Dental Medicine, and very involved with funded some of my funding from the NIH, and he'll tell you more. I want to get this started, but feel free to put anything in the Q&A. And George I'll be reading off your questions at the end. So I want to thank you. I know you had a really, really busy day, as we all have, and making the time for our group. We're very excited to have you. So go ahead and take it away, George.
Thank you, Alan, and thanks everybody. I know it's tough to meet, at 6:30 on a midweek afternoon, and I appreciate everybody from coming here, and I appreciate the opportunity to interact with the group. Like Alan said, I'm a professor of oral biology and the clinical research dean at Rutgers, and I also direct research here. We have, I'm going to be speaking today about peri-implantitis and the risk associated with empirical dental treatments. And I will tell you that I've been desiring to be able to put together an evidence-based presentation on peri-implantitis for many, many years, simply because we weren't even asking the right questions. So it took several years to start asking the right questions before we eventually got to the point of being able to get the evidence and be able to address this major problem. Now, these are all the sponsors that have funded us through the year, and some disclosures that I have here, so please read those carefully. I'm glad to let you know that now we have multi-million-dollar funding from the NIH to specifically interrogate peri-implantitis, which is important. It contributes to the realization that peri-implantitis is an impactful public health issue now. It's a very prevalent disease, and currently it's a disease without a cure. So this has been a collaborative, a team effort, and you can see here a number of people for the past 10 years that have worked with us, and now this is my group here at Rutgers School of Dental Medicine that we're actively being engaged for a decade nonstop on peri-implant research. So I'm going to try to distill today what we've learned through the years doing peri-implantitis research. Now, because we're a small group of specialists, I'm inclined to do this as more of a loose presentation, and feel free, if there's a burning question that's alive for you, feel free to put it in the Q&A and I'll try to address it. Maybe Alan can pass that on to me, because I'm not sure. Oh yeah, I'm going to have access to the Q&A. So if there's a burning question during the presentation, please go ahead and put it in the Q&A. And I'm going to be jumping back and forth into slides because I think that as specialists, you're very familiar with the topic, and I just want to try to summarize everything into this 45 minutes. So starting, a fundamental question that we got to ask when it comes to peri-implantitis is titanium a foreign body? And many of you might be very familiar with this kind of debate in the literature. I want to bring up one of Tom Wilson's studies. If you don't know him, Tom Wilson is a very prominent periodontist and great researcher in Dallas, Texas, kind of doing practice-based research. And early on, about nearly a decade ago now, he looked at peri-implantitis tissue sections that he got from patients with peri-implantitis, very simply because of the aberrant phenotype of the disease. And he looked at 36 biopsies of peri-implantitis tissue that he procured during surgery, and 34 of them included titanium particles within the tissue. You can see them here, and I believe you see my mouse on the screen. You can see them here as black dots right in the middle of tissue, and you will note that they're associated with cell death around them. There's no live cells in between them. And here it's tracking them with an expensive EDS microscope to confirm they're really titanium. So we know very well out of Tom Wilson's studies and a number of other studies, including studies from my group, that peri-implantitis in humans is associated with titanium particles. We also know, as you can see here, that peri-implantitis has a very, very distinct phenotype when it comes to the spatial architecture of these defects. And you can see how well circumscribed these defects are. It's almost like somebody started a radius to form a circle around that implant. How well circumscribed they are in the jaw, self-limiting to around the implant, or even in case of multiple implants, possibly around to a specific implant. And they don't affect adjacent teeth, which is very different than the paradigm in periodontitis. So that would really fit the hypothesis that titanium is a foreign body. However, the answer is yes and no, because titanium implants are among the most successful biomedical biomaterials across all medical disciplines. Nowadays, with modern surface technologies that we have, we can accomplish up to 100% primary integration in very challenging cases like poorly controlled diabetes, for instance, right? So implants are extremely, extremely successful devices. So that means that titanium is highly biocompatible. That doesn't mean, however, that titanium cannot become a foreign body. I want to emphasize this study. And by the way, at the end of the presentation, I'm going to give everybody a QR code and a link to my website. And there we've created a catalog with all our studies over the years. So you can go ahead on my website and download these PDFs for free if you would like to get more information. So I'll have a link in the end. Now, we wrote a paper with Thomas Albrechtson, one of the standing members from the original Brandmark team of osseointegration, Dave Cochran, and other experts. And we called that paper Osteoimmune Regulation Underlies Oral Implant Osseointegration and Its Perturbation. What this complex title tells us is that really, when we place implants, these implants are not bioinert. We don't place them in the tissue and they integrate and the bone anchors them and they're done. It's actually a complex, dynamic, and continuous surveillance process that takes place where the immune system constantly sees two things. The first one that it sees is bacteria. Because these implants are transgingival fixtures, right? They come out from the tissue. We have constant saliva coming in, biofilm, plaque biofilm from other extraoral and intraoral sites. And as a result, we have this continuous triggering of bacteria, even if they're pathogenic or if they are commensal, right, of the immune system. So we have immune system training by the bacteria in the peri-implant sulcus. And at the same time, we also have another signal to these immune cells in the peri-implant soft tissue coming from underneath, coming from the implant surface, and that is the biomaterial itself. So constantly, these cells are there, primarily macrophages, neutrophils in case of a little bit more acute inflammatory content, plasma cells and lymphocytes, and dendritic cells, constantly surveilling and making sure that the biomaterial is intact and is not leaking into the tissues. Because if it were to be leaking into the tissues, other things would need to happen to limit that danger from transversing systemically. Now, because of this fundamental difference, the fact that we not only have the bacteria as we have around teeth, but we also have the biomaterial training the immune system and causing an equilibrium to be reached between bone, bacteria, and biomaterial, right? We have to look at peri-implantitis as an ecosystem-specific issue. And we have a lot of evidence about that have really steered the way we look at peri-implantitis, and I'll talk more in depth about it. But just to provide perspective, we wrote a Perio 2000 article with my friend Daniel Olmedo, a great pathologist from the University of Buenos Aires, Argentina, that did foundational work on peri-implant tissues and uncovered titanium particles in them and then linked it to orthopedic implants. And we talked about how the difference in electrostatic forces, the difference in surface energy between the implant and an organic substrate that is the cementum, the root of the tooth, make for a very different biofilm environment, night and day, even in health. And then there's a number of studies, including Purnima Kumar's study, that showed that the peri-implant microbiome has more dissimilarity to the periodontal microbiome that has similarity. And that alludes to the fact that periodontal antibiotics that we like to use, like let's say amoxicillin, metronidazole, may not be effective against peri-implantitis. And as a matter of fact, we have data showing that they're absolutely not affected across the board in peri-implantitis, and we should hardly limit the application of periodontal antibiotics for peri-implantitis to minimize their misuse. Now, I want you all to view peri-implantitis as a perturbation of that ecosystem that I described before, that ecosystem of bacteria, biomaterial, and host bone maintenance mechanisms that create an equilibrium in health, right? And that is what we refer to as crestal bone remodeling early on, once we try to reach that equilibrium, and then we refer to it as crestal bone stability, once that equilibrium has been reached within 6 to 12 months after placement of a crown. Now, if you look at this peri-implantitis case that I'm showing you right here, through that prism, what you can perceive here is that we have a disequilibrium, right? So from that point where we had that balance, that initial crestal bone remodeling and the bone settled somewhere around the neck of the implant, as we call it, now we have a disequilibrium, and we have really rampant bone resorption that approximately in this case has reached to maybe 50% bone loss. What does that mean? That means that there are two triggering factors in this particular situation. One is the bacteria, but another one is the biomaterial. And I think it's extremely, extremely important when considering peri-implantitis to start thinking about the biomaterial as playing a role in disease, because then you will see that when we start thinking about the biomaterial as playing a role in disease formation and we try to manage it as part of disease resolution, we have much greater success. So moving forward here, there are also other host factors, such as in this case, smoking, that contributed to this rampant inflammatory bone loss on almost all implants for that patient. Now, smoking is a systemic factor. There can be other site-specific factors. For instance, this is a case that I was seeing with Dr. Hossein in San Antonio, a periodontist there. And in this particular case, an implant started exhibiting, for unknown reasons, peri-implant bone loss in a patient with otherwise excellent oral hygiene, excellent periodontal status. And lo and behold, we observed that there was a strand of floss that was retained in this specific situation because of what you see, a kind of a problematic conic point in the vicinity between the adjacent mesial tooth. So you can see how this strand of floss that was lodged in there was functioning as a ligature pretty much, collecting plaque and leading to the very local site-specific breakdown. So sometimes it takes a systemic factor, sometimes it takes a local factor to perturb that equilibrium. Now, moving forward, I want to remind you all, and I think we're all specialists here, so I don't really need to put a lot of emphasis on that, but it's important to remember that titanium in itself is not biocompatible. The implants are not osseointegrating because of titanium. They're osseointegrating because titanium has the proclivity to form a very unique thin crust on its surface that we call titanium passivation layer, or you might have heard of it as a titanium dioxide layer because it's over 97% titanium dioxide. And what that does is it provides a very controlled primary corrosion process. We reached the consensus with Thomas Albrechtsen when we were writing a series of papers together to not call this foreign body, but to call it primary corrosion and secondary corrosion. And what primary corrosion means is that if you see up here, that's a Ti-Unite implant, that black area. If you see right here, there's a gray crust right on the titanium implant, and that's a very thin line of titanium oxidation that has occurred when that titanium was taken out of the box and exposed to atmospheric air, and it's self-limiting. So it's not going to keep corroding like steel would probably corrode or other alloys would, but it performs that passivation layer that is stable over time. And that enables the osteoblasts to migrate towards that area. The blue dots that you see are osteoblasts, and start building osteoid, and eventually in the bottom of the screen, you see what osseointegration looks like clinically, and it's the layering of titanium, which is the black area on the lower left-hand side of the screen, a very thin gray crust on it, which is the titanium passivation layer or titanium dioxide layer that is barely visible in that image. And on top of that, we have osteoblast, mineralized lamellar bone, and then on top of that, osteoid and more osteoblasts like little caterpillars building more and more bone for osseointegration to occur. So be very mindful of the fact that in teeth, we have this replenishable, regenerable area of cementum or even dentin, versus in titanium, if we lose that titanium dioxide, then you reveal the metal, which is not biocompatible. No metal is biocompatible in the human body. If we had bulk titanium metal without that passivation layer, that would be absolutely, and is, as we will see, cytotoxic. Now, moving forward, patients are quite vigilant, knowing that implants now actually do fail, right? And they come and say, well, do you have a warranty? Or if you place that implant for me, how long is it going to last? And they know because the prevalence of peri-implantitis is about 20% on a personal level. So they probably have met somebody who said, I have a terrific implant, but they've also met somebody who said, I got pus coming out of that implant. I went to that doctor. I had to pay $5,000 more to get it fixed, and it's still problematic. So what do we do in that case? The good news is that we now have a classification of periodontal and peri-implant diseases and conditions. And that's important because it took about 35 years to get to one after the World Workshop in 2017. And I was privileged to, along with Jim Heinrichs, my old director from the University of Minnesota, to be able to write that in the Carranza's and Newman's Clinical Periodontology. So what this chapter says in a nutshell is that we now have a classification of peri-implant diseases and conditions, and we can break peri-implant diseases and conditions down to peri-implant health, peri-implant mucositis, peri-implantitis, and then peri-implant soft and hard tissue deficiencies. And what's central to diagnosing these 4 diseases and conditions is that trifecta of probing, radiographs, and visual inspection. And out of all these, because of a lot of intricacies associated with implants, probably the most important thing would be probing. And we now know very well that it's actually safe to probe implants. And there's some nuances in that, but I would say that overall, you should all be very familiar with the literature by now, across all specialties, from oral surgery to perio to pros, that it is safe to place implants as long as some prerequisites are being met. And I'm showing you an example here. I've had kind of a heated discussion a few years back with an academic periodontist wanting to train their dental students in using plastic probes. And if you're a clinician, you know the plastic probes do not work around implants because they got to be so bulky and so rigid in order to place them in a peri-implant sulcus without breaking that they're not clinically relevant for the majority of implants, especially with the way the superstructures are. So plastic probes are great for taking photos during surgery for the nice contrast they do with the camera, but that's about it. Metal probes are the way to go, and they're safe. But again, it is essential that we use a light force that will not damage the peri-implant tissues. And the second nuance there is that it is very important to have a baseline healthy measurement because the biologic width is surgeon-driven around implants. If I place an implant 2 millimeters subcrestally in a patient, and then right next to that implant, I place another implant 2 millimeters supracrestally, again, same patient, these implants are not going to have the same healthy baseline probing sulcus depth, right? This implant is going to have about a 4 or 5 millimeter healthy peri-implant probing depth at the time of implant restoration, a few months after implant restoration. The other implant might have a more shallow initial probing depth of 2 or 3 millimeters, maybe even 1. So extremely important to have a healthy baseline after loading. Now, moving forward, why is it important to probe? Well, because primarily we have 2 main diseases: mucositis, that is extremely prevalent, about 60 to 70% of implants at any given point in time, and peri-implantitis, about 15 to 20% of implants at any point in time. And peri-implant mucositis is extremely important to diagnose early for the primary prevention of peri-implantitis. Even with the techniques that I'm going to show you today, we're successful in about 70–75% of implant cases on peri-implantitis regenerative treatment. Versus in case of mucositis, we have much higher success rates when we intervene early on and we manage local factors in oral hygiene and avoid progression of that into peri-implantitis. Going back to the point of probing, which is a message that I definitely want to get through today, the healing after standardized clinical probing of the peri-implant soft tissue seal has been reviewed in many studies. This is one particular one that I like. You can take photos if you want. And what these people did at Houston is they placed probes in dogs in peri-implant sulci with different amounts of force, and some of those ruptured the epithelial seal. You see that point here of saying JAJE. That means apical point of the junctional epithelium. That's where the tissue seals onto the implant, and you can see it clearly ruptured here. And you can see that with appropriate oral hygiene in the dogs, 7 days later, there was complete reattachment of the junctional epithelium at the same level. So we didn't have attachment loss, right? Detached, and a week later, reattached at the same level. Now, knowing that, I will say that we don't want to have that happen in our patients because, number one, dogs heal way, way faster than humans. And then secondly, and very importantly, not every patient has impeccable oral hygiene. You don't have them every day there to brush their teeth as you do with the dogs in these studies. So I want everybody to be mindful of the fact that there's a pain area right here. And what I mean by pain area is that when you probe the peri-implant sulcus, patients shouldn't feel pain. And they shouldn't feel pain because epithelium doesn't have any nerve fibers. So what does it mean if I probe a patient and they jump out of the chair, or they do back with their heads? That means that I don't have situation on the top where I put the probe and the probe stops at the junctional epithelium. I have the situation on the bottom where actually my probe has now pierced through the epithelium and it touches the connective tissue that we call lamina propria. So we don't want that to happen. This is the reason why I'm very specific on implant-specific instruments. And you'll see that I use exclusively implant-specific instruments for both maintenance, non-surgical intervention, and to the extent that we have them for peri-implant regenerative treatment. So there's a couple of probes in the market that are actually more flexible, are made out of softer alloys, and are made of titanium and are thinner than the actual one. This is one, and I have to disclose to you that I do have a financial interest because I've designed this probe, but that's not the only one in the market. There's at least a couple that I know of in the market that are implant-specific probes. So you don't need to have this specific one, but you better have an implant-specific probe that is more flexible. So that means that because the epithelial seal is not as robust, I don't have dendrogingival fibers. I don't have a lot of circular fibers around that peri-implant sulcus. And there's chances that instead of flexing the tissue, I'm going to pierce through the tissue. It's better to have a flexible probe, a smaller probe, and in case it touches the implant surface, a titanium probe. So implant-specific modalities. And controlled pressure, which means that the patient should never, even in inflammation, feel pain when we probe the peri-implant sulcus. For the same patient today, it might be okay to put 0.15 grams of pressure. For the same patient tomorrow, if they're very inflamed, I might need to go down to 0.1 or 0.05 grams of pressure. And there's no way to calibrate that rather than going slow and putting it in to the point that the patient doesn't feel pain. Now, moving forward to peri-implantitis, and I need to go a little bit quickly because we're going to get into the nitty-gritty. I'm going to skim through this part really quickly because everybody's familiar. Peri-implantitis now is defined as bone loss of at least 3 millimeters with probing depth of at least 6 millimeters according to the peri-implant classification. And here's a nice question that I tend to hear very often is, why care about peri-implantitis when I can just take it out, right? And I agree that based on what we know today, and that stands for hopeless teeth as well, the most predictable way of managing peri-implantitis is take it out and start over again, no doubt. But take a look at this patient that I treated when I was in San Antonio. He was seen by a colleague in the Valley, which means south, really, really deep South Texas. Had 5 implants placed in the lower jaw, When I saw the patient, he's already lost, excuse me, I think he had 6 implants placed. When I saw him, he'd already lost a couple of implants and was about to lose this one back here, right? But the problem was that 2 years ago, this patient had paid $17,000 for that zirconia hybrid frame that you're seeing there. And now what happens if I lose the distal abutment? Well, what happens is the patient can't wear anything, right? Because I'm going to remove that implant. I'm going to do guided bone regeneration, very predictable. But the patient has to walk for at least 2-3 months for not disturbing my sight, right? Edentulous. And there's not enough support there to put a pontic now because I've lost so many implants. And I would have probably reloaded with just 3 implants in the lower jaw. Versus if I'm able to do peri-implant regeneration, that's the early healing that you see here about a couple of months after our treatment. And if I'm able to give this implant another 5 years, this patient is extremely satisfied, extremely happy that we increased the lifespan of that implant, and an amazing referral source himself. Now, I want to move a little bit faster here. Everybody, I think at this point, since we're specialists, is aware that lack of keratinized mucosa is an extremely big issue, and I think it should be the #1 referral we get towards perio from general dentists, restorative dentists. That should be in cases of limited keratinized tissue, as you can appreciate in this case here, where we've got a big GBR, and now there's no keratinized tissue left. Go ahead and rebuild that keratinized tissue. Make sure that we have long-term longevity and peri-implant health around that implant. And of course, other issues we see that are not peri-implantitis per se, but fall into the categories of peri-implant soft and hard tissue deficiencies is the classic implant that was maybe placed as an immediate in the anterior zone, thin buccal plate. The buccal plate was there at the time of placement. Now the patient comes back with discomfort, and when I open up, I can clearly see the threads of the implant protruding outside the buccal plate that has now resorted. Okay, a classic case of not peri-implantitis is very easily addressable with a soft tissue graft, peri-implant soft tissue deficiency. Now, moving forward, we got about 15 minutes left, and I want to make sure that we cover a little bit our protocols and why we do what we do. So peri-implantitis is characterized by very rampant and very localized disease progression. And it's very important when we're thinking about what's the cause of disease to revert it, to not limit our thought process to bacteria, as I said before. Now, this is the 2013 AAP consensus report. That's the last one that was done until later this year, the AAP consensus conference that is put together. And I don't know if Paul Rosen is with us today, but he's leading that. And we're going to have some really, really important updates. But to tell you where the field was at the last consensus report, if you got a periodontal resident, if we have periodontists in the room, that I see we do, and they go to their boards, they will say that periodontitis occurs primarily as a result of an overwhelming bacterial insult and subsequent host immune response, right? So tracing that back, peri-implantitis was thought to have the exact same pathogenetic mechanism. However, that led to what I like to refer to as the periodontal infection model. And that means that we tried everything under the sun to be able to grind those implants and get rid of the biofilm, throwing mechanical or chemical. This is a paper, again, you can download that from my website. This is a paper we did with a lot of renowned experts in peri-implantitis. Alberto Monge and Homley Wang put it together. Dennis Tarnow, Frank Schwartz, Tony Scullion, Stefan Ranbert, and other folks joined. And we summarized pretty much everything that people have attempted to do to clean implants. And you can see here the 4 most common modalities for mechanical cleaning were metal scalers, and you can see how severely abraded the implant is from these metal scalers, plastic scalers that leave these plastic remnants, air abrasive device that has minimal effects on the surface, and a titanium brush that fundamentally changes the surface roughness, which means that it doesn't really grind off the material, but removes the titanium passivation layer. And then when it comes to chemical, on the other hand side of the screen, again, you can see anything from non-cytotoxic sterile saline to acids like citric acid, extremes like phosphoric acid, the same thing you etch enamel. People have put that in intrabony defects, chlorhexidine and whatnot. But overall, looking at I recently looked again at all the available peri-implantitis interventional studies in humans for a consensus report that we're writing for the iADR on peri-implantitis best evidence. And this is the most commonly employed mechanical intervention. Long behold, grinding the implant surface, right? I could play this for hours, but it's the same thing, grinding and grinding and grinding until we feel the satisfaction that it's been cleaned enough. However, there's a fundamental issue here in that around teeth, we have calculus, but around implants, we just don't. We have calculus, don't get me wrong. We have calculus on these machined abutments. We have calculus on the supramucosal interface because it interfaces with minerals in the saliva all day long. But because of their surface energy, these micro rough surfaces submucosally do not get calculus. It's a very, very rare instance. So what we're fighting is not really pathogens as in periodontitis, but it's the combination, the synergy between pathogens and titanium microparticles, as I was telling you before, that Tom Wilson and others have found. So really, calculus is not a major issue. And here I'm showing the only one study that has looked at it actually so far and concluded that it's really not an issue, it's not existent. But when it comes to evidence, and before I get to evidence, we have a question, and I can tackle it now. And please, people, keep writing in the Q&A as we go, because I know that we have limited time afterwards for Q&A. The question was, what is the suggested probing timeline from restoration? The consensus of the World Workshop says 6 to 12 months after loading, you should get your baseline probing depth. So ideally, a year after loading is when you should get your probing depth. For me as a specialist, that means that whenever I write a note to my referring restorative dentist for an implant that I placed, I tell them that I would like to do the 1-year follow-up for that implant and get the patient in for a cleaning so I can get their health baseline probing depth. Now, going to the evidence, the problem is that with all these anti-infective strategies, grinding implants, throwing chlorhexidine, and yada, yada, there came out a Cochrane systematic review, the most authoritative form of systematic reviews in 2012, and said that follow-up longer than a year suggested that recurrence of peri-implantitis occurred in up to 100% of these treated cases, up to 100%, which is a massive number. It would translate to me telling a patient you got about a 0% chance that this is going to work. And then when you consider antibiotics, adjunctive systemic antibiotics had no positive impact on treatment success whatsoever at implants, right? So no scientific evidence, no sound scientific basis is available for the use of systemic antibiotics, at least for the use of periodontal systemic antibiotics against implants. Now, I want to use chlorhexidine as a paradigm. And by the way, I don't use chlorhexidine anymore in my practice. If I use chlorhexidine, what I'm going to do is I'm going to have it in a cup, and it's in a cup. And in case a screwdriver falls on the floor, and we don't have another one available, I'm going to put it in a cup with chlorhexidine for 5 minutes to decontaminate it, and then wash it carefully before putting it, in the mouth to remove that crown. Never use chlorhexidine surgically, and I'm going to show you in a little bit. Well, actually, we don't have time to do today, but chlorhexidine is extremely cytotoxic to fibroblast soft tissue cells and bone cells. And I'm going to use it as a paradigm to show you why biomaterial needs to be considered when we're doing peri-implantitis treatment. So if you look at the antimicrobial effect, this was actually part of my thesis work at the University of Minnesota. If you look at the antimicrobial effect of chlorhexidine, these are control implants that are covered with biofilm, and you see how many bacteria they have on top of them. These are implants treated with saline, and just saline alone doesn't really kill the bacteria, of course. And then this is where chlorhexidine stands. It kills some of the bacteria, but not as many as citric acid, for instance. Chlorhexidine is a very poor antimicrobial when it comes to established biofilms. The reason why we give it around teeth is to prevent biofilms from adhering, but after cleaning them with SRP. So the problem with chlorhexidine is that when you clean an implant, and you try to grow bone cells on it. And this is what we did in this study. We're growing bone cells and we're tagging them with a blue fluorescent dye. So every little blue dot that you see is one bone cell, one osteoblast. And you can see here that in the sterile control, these are osteospeed surfaces, by the way, acid-edge surfaces with hydrofluoric acid. Bone cells love them. But when it comes to chlorhexidine, bone cells don't want to reattach on that surface if chlorhexidine has touched that surface. And the reason is chlorhexidine has substantivity, which means that it sticks on the surface, and then, excuse me, for multiple days, it has a protracted cytotoxic effect on pretty much any adjacent cell. So all in all, what we did in a subsequent publication is that we were trying to break down and give you all a classification, and please take a photo of this, trying to give you a classification of anything that can be used for implant surface decontamination. So we broke it down into mechanical means, and we further break this down into contact and non-contact and abrasive and non-abrasive, and I'll show you in a minute why they're important, and then chemicals. And the chemicals, we break them down into chemicals that have non-selective cytotoxicity, which means that they kill anything and everything under the sun, or selective or no cytotoxicity. So just to tackle the chlorhexidine paradigm, I really want to show you clinical evidence because we're clinicians at the end of the day. And what we did here was we used a dog model in which we create ligatures around implants. That's called a ligature-induced peri-implantitis model. So what we do in this model is we first extract the mandibular teeth of the mandibular premolars of the dog, and then after healing, we place implants, and you can see here 4 implants placed. And then after implant placement, we do primary closure because the dogs can go crazy and they can knock those abutments out. And then eventually, once the implants heal, we place ligatures. These ligatures are the same retraction cord that you place when you're doing your impressions for restorations. So we place these ligatures and look at the massive, in the middle picture, look at the massive accumulation of plaque that eventually causes inflammatory disease and peri-implantitis, as you see on the right-hand side of the screen, that's very similar in configuration to human peri-implantitis. That's a very challenging, very expensive model. This whole study that I'm showing you here cost $250,000, and it takes about 64 weeks to completion. So it's very, very resource time intensive. But it was very important because we were able to ask a fundamental question. We got 3 peri-implantitis defects. One defect was the control. So we just irrigated with saline. We didn't put bone graft. And then the other 2 defects, one got cleaning with chlorhexidine, and one got cleaning with dilute sodium hypochlorite. And we got that dilution of sodium hypochlorite of approximately 1%. And that is if you take the sodium hypochlorite, you use an endodontics, and you dilute it 1 to 6. So 1 unit of the sodium hypochlorite, which is 5.25%, and about 5 units of water, then that gives you this dilution. And the reason why we use that is because they use it in regenerative endodontics and what they call Regendo, and it is not cytotoxic to bone mesenchymal stem cells. So all in all, we have dilute sodium hypochlorite versus chlorhexidine versus the control. And what we found in this study is that when we use sodium hypochlorite, we had a probing depth reduction. Mind you, these are short implants because of the dog. These are 8-millimeter implants. We had about 1 millimeter reduction on average in probing depth after doing peri-implantitis treatment with the same bone graft, with the same membrane in all dogs. And then in the next study, in the chlorhexidine study, actually in the next group, in the chlorhexidine group, we have 0 change, which means that after cleaning these implants intensely with chlorhexidine, adding so much bone graft, adding a membrane, we have 0 improvement in probing depth 4 months later. And even in the control where no bone graft was added and there's just saline was irrigated, even there we have some improvement of about 1 millimeter in probing depth. But what was even more impressive was that in the sodium hypochlorite group, we got really good reosseointegration, which means reattachment of bone on these implant surfaces. In the most cases, in some, like number 24 here, the bone remained stable, but we weren't able to get regeneration. However, in the chlorhexidine group, we had rapid deterioration of the bone. And as you can see here in section number 18, you can see that the implant now continued to lose bone even after all these interventions. And now it's about to pop out. Or in some other slides, like in slide number from dog number 5, we had bone grow vertical, as you can see here on the side, because regeneration worked, but the bone wouldn't touch the implant surface. There's a gap here, which might not be perceived clinically or radiographically, because this is, X40 magnification under microscope, but it created a necrotic zone, chlorhexidine, because of its substantivity and cytotoxicity, created a necrotic zone. So on average, we had about 40+% bone fill with using sodium hypochlorite and less than 20% with chlorhexidine. So it's really important to start thinking outside of the box and forget about that periodontal infection model and really see the data and look at this implant degradation disease model. And what we did afterwards is we transitioned to the human. And as we're wrapping up the presentation, I just want to show this proof of concept study that we did. And this proof of concept study is also corroborated by other groups. And there's actually a human re-osseointegration case report by Paul Fletcher here from the Northeast, showing that you can, with minimally invasive approaches, with saline pretty much, cleaning and no abrasive mechanical interventions, you can have re-osseointegration in the human, which is very impressive. So what we did here in this proof of concept, we just touched the implant surfaces with sterile saline and no other chemicals. And this is the situation after 9 months of regeneration in this particular case. And I've done a partial thickness flap here because of lack of keratinized tissue. But what you can see under the periosteum is hard tissue that resists probe. And this is how the case was at initial entry. You can see the massive granulation tissue around this implant, removal of the granulation tissue, cleaning with just sterile saline. This is an older case where we were using cotton pellets. Because they fray, we don't use them anymore. We use gauzes to burnish these implants, as I'll show you in a little bit. And then following that, I have a clean implant surface now. Intramural perforations, because the osteoregenerative potential of peri-implant defects was very low because of the presence of titanium there that's blocking some blood supply. Placement of infuse, because one key thing in peri-implantitis treatment that we found is that osteoconduction won't cut it. You open up and you put a demineralized bovine bone mineral alone or an FDBA alone, it's not going to cut it. We need osteoconductive and something more. So in this case, we're using osteoinductive recombinant human BMP2. Of course, if you've ever used infused, patient gets very, very swollen. It's very hard. It's not an abscess, it's just rapid neovascularization. And this is the radiographic situation at entry. This is the follow-up with a partial thickness reentry for a pharyngeal graft. This is early healing of the pharyngeal graft. And this is the situation at 3 years later. And you can appreciate that we haven't covered all the threads of the implant, but we have very, very reasonable, about 40–50% regeneration. And then the remainder threads are covered with soft tissue. That's a sustainable result. And now that's another case. I don't have time to show you a lot of cases before. That's another case of showing you how with this minimally invasive approach, with just touching the implant with sterile saline, we can reconstruct the buccal plate here. We can have at least radiographic bone healing and long-term sustainable result. The key with peri-implantitis is always looking at it at least a year later, right? Because early results might be great if you grind the implant, but later on they won't be. And to close, there's a specific protocol that we use, and I'm going to share with you all in a link. And this protocol is called a non-abrasive approach to treatment of peri-implantitis. And the reason why we do that is because we run a clinical trial now to say, okay, forget about the chemical, but what if we also get to mechanical? And then we started this study doing entry of moderate or pretty severe peri-implantitis cases, as you can see right here, and doing one of two things. Either using a titanium curette, as most people do, to grind the implant as best as we could and make sure that there's no visible biofilm, and then put a lot of bone graft. This is a combination of an osteostimulated calcium phosphosilicate morsel, the Nova Bone morsels, with a cytoplast RTM collagen membrane from Osteogenics here, who was the sponsor of this study. And the other group got a nylon brush for treatment. So we're comparing mechanical abrasive to mechanical non-abrasive. And you can see here that consistently in the abrasive group, what we noted was that implants ended up deteriorating. After this massive grafting, they would start from a set defect, and eventually this is subtractive automated digital radiography here. And any red area shows you area of continued bone loss. So you can see that even within 5 months, we had severe continued bone loss in this specific situation after upbraiding the implant surface, and eventually that implant did spontaneous exfoliation. I'm going to go really quickly to show you the results of this study, and then I'm going to show you what we're working on right now to wrap things up. So what was very impressive with this study is that we asked 2 questions. The first one was whether abrasive implant surface treatments result in accelerated titanium dissolution clinically, a very important scientific question, because none of it would make sense if I told you, titanium particles are an issue, but you can grind an implant and the implant's fine and it's not going to be leaking titanium particles. And then the second clinically relevant question is, no matter whether it has particles or not, does that affect the treatment outcome for the patient, bone regeneration? So in one group, we compared mechanical abrasive. The other group was implant-specific mechanical non-abrasive. That's a rotating nylon brush for the implant. So what you can see here is an example of plaque that we took out of a patient, and we looked at it under the transmission electron microscope. This is about 500 times magnified, and you can see titanium particles in the plaque matrix. And we were able to measure those with a process called ICP-MS in humans, which is very neat. You get a plaque sample from the human, and you can know down to the part per million what the concentration of titanium in their plaque is. So looking at the group here on the left-hand side of the bar chart of using the nylon brush, the change from baseline, which is the blue, to the post situation, which is the red, was minimal. So there was no significant increase in how these implants were leaking titanium over an 8-week period. And by the way, we took one plaque sample at baseline where we started cleaning those implants, and then non-surgically. And then we took a second plaque sample when patients returned 8 weeks later to look at the effect of non-surgical treatment right before they went into surgical. So there's an 8-week interval. So we're not really measuring the direct effect of cleaning. We measure whether cleaning removes titanium dioxide and eventually these implants leak titanium particles. And you can see on the other group over here, we have titanium concentrations on the y-axis. This is the baseline situation with some titanium in this group. And look at the massive, massive release, about 10x greater titanium release in the titanium curette group at 8 weeks post non-surgical treatment. So when we looked at the cases treated with the nylon brush, the non-abrasive way, then we had the expected outcome. You can see green now, which means we have bone regeneration, and a lot of these cases regenerated. As a matter of fact, when you look at them on average, in these cases, we have a little bit over 1 millimeter on average bone gain after 5 months, and now we're looking at the 12-month data. And then in the cases where the titanium curette was used, we have virtually 0 bone gain, right? And we have on the negative, look at that tail down here, we actually have bone loss in many of those implants. So that's a very loud answer to the fact that if you use an abrasive treatment, clinically, that will result in poor clinical outcomes. And that can possibly account for a large part of cases not being able to be treated. So I'm going to stop right here, I think, for today, so we can have our Q&A, and I'm going to show you, and I'm going to leave it to this just in case we have more discussion. This is my non-surgical management of peri-implant inflammation protocol, and then at the end of the presentation, I'm going to leave you all with a QR code and my website link where you can download the non-surgical protocol, the surgical protocol that are both evidence-based, and come back and download any of the papers that you want. So with that, I think giving it back to you, Alan, for the Q&A.
Okay, great. Can you hear me okay, George?
Yes.
Sorry about that. I'm on an iPad now. My technology's improving. Colin Richmond asks, have you had any experience? By the way, this was great. I know you had a long day like myself, and I appreciate your time. Colin Richmond asks, have you had any experience in using the LaPip with the Nd:YAG laser for the treatment of peri-implantitis? Of course, Rutgers is a training center for this protocol.
Yeah, that's a good point. I'm not trained in LaPeep, and we don't use it. The reason why we don't use it for peri-implantitis treatment is because that's knowledge transfer from periodontitis. We know why Lanap can work in periodontitis, and there's some cool studies showing, I believe, that it can work. On LaPeep, it's just not evidence-based at this point. And the problem with the strategies is dual. First of all, there can be deleterious effect if you zap the implant with the wrong wavelength in terms of removing the passivation layer. Secondly, a lot of this, I know that LaPeep can work, but a lot of this has to do with reproducibility. So, the creators of LaPeep have never funded a randomized control trial of peri-implantitis to tell you out of 100 cases that we can treat 50 successfully, 60 successfully, 90 successfully, or one. I know that I can have one good case report, but how reproducible is it? So I'm not saying it's not. I'm saying that we only apply evidence-based protocols, and we kind of put them to the test. And I just don't know why they haven't done a randomized clinical trial yet.
Okay, great. Following up with that, another member has asked, what about using the erbium YAG laser? Any research on that, or any random studies?
Yeah, there's a lot of studies preclinical now for the erbium YAG. We have a lot of in vitro studies showing that the erbium YAG can safely touch the implant surface and it will not damage it in any way. It's actually going to remove biofilm. Problem with it is that both my group and Homley's group, we did a meta-analysis on the topic because it was of interest. They both got published in the same issue, actually, of J. Perry in 2015, and both found that erbium YAG is safe, but if you use it for non-surgical, it's as effective as plastic curettes with cotton pellets with saline. So I think, Occam's razor, you go with the cheapest approach. That's why we don't use it right now.
Great. Bobby Horowitz says, great presentation. Thanks for sharing the results. Sorry if I missed it, but what percentage do you dilute the bleach to? And I guess you'll have this later anyway.
Good to see you, Bobby. We do about 1:5 to 1:6. Where you want to be is about 1% of sodium hypochlorite, and what we get in endo is 5.25%, like household bleach. So about 1:5 to 1:6. However, it's not critical. We see that even if you do sterile saline, you can get pretty darn good results. So I would say even if you dilute it even more, even to about 1 to 10, that would be safe because we have dog data for sodium hypochlorite, but we have human data for sterile saline. So just don't go aggressive. Less is more with peri-implantitis. So even a 1 to 10 dilution could be great.
Forgive me, this may be this is my question. So when we were early trained in Branamark, we were told not to mix stainless steel and titanium with instrumentation. You mentioned that with probing, if you hit the implant, not to use anything but a titanium probe. So would there be a reaction if you hit it for a second with a stainless steel probe, or what would happen? Why that comment?
So there's no, I mean, there's an electrical current going on whenever you put two metals together. Yeah, but that's not going to be detrimental if you just touch it for a second. The issue there is that, as you know, titanium, even titanium, aluminum, vanadium alloys are some of the softest alloys we have. So pretty much any other metal you use is going to be much harder. And it's there's a metric that people who make instruments use. It's called Rockwell hardness. So pretty much everything will have more Rockwell hardness than titanium and will abrade it quite a bit. That's why I'm a great advocate. When you're examining implants, your entire kit has to be made out of titanium instruments. And not only that, but when it comes to titanium curettes, that if you download this protocol, the implant safe protocol that I have on my website that I'll show you in a bit, you'll see that I specified to never use titanium curettes on the implant body. They're only made for abutments, right? For anything that is supramucosal and can actually get calculus. And even so, they have to be soft titanium curettes because every alloy of titanium has different hardness. So you want an instrument that is softer titanium alloy than the actual implant.
Great, thank you. Please comment on the quality of titanium that the implant is made from. that is pure titanium to various alloys.
Yeah, I think we briefly touched on that, right?
Mhm.
The majority are grade 4 or grade 5, and there's some implants in the market that are just a pure titanium grade 4, or they can be a titanium grade 5, the titanium aluminum vanadium alloy. And as of now, we don't know of any clinical data that one has more peri-implantitis than the other. It has more to do with the surface modification.
Would you care to comment on the use of the EMS GBT protocol with erythritol? How do you feel about that?
Yes. Another issue there, people come, EMS is a perio company, right? And they come up with glycine powder for perio, which works great. And then they think because you can't really treat implants easily that they need something more, and they come up with erythritol. The problem with erythritol is that on the one hand, you have glycine powder, which is an amino acid, not abrasive at all, just an amino acid, right? And you get erythritol, which is actually these little spheres that carry antimicrobial properties. So you're blasting the implant with something that is more abrasive just because you want the antimicrobial properties. So I would say if you want to polish an implant surface, use the glycine powder. Glycine powder is extremely effective in removing biofilm from implant surfaces. I will say, however, that there are cases of emphysema, as you know. If even with non-surgical use now, if you point it towards the sulcus and you have very inflamed tissues, even non-surgically, air can go through, you can get emphysema. Patient's eye is going to close on the same side, and they're going to go to the hospital for IV antibiotics. And I was just in Europe lecturing a few months back, and Andreas Stavropoulos from, I think he's in Switzerland now, or Sweden, he showed a case of an air bubble from the use of EMS for cleaning implants going to the brain. So I don't even want to know what insurance companies would think if they saw that on this side of the ocean. So for this reason, we never use EMS with glycine powder, but there's ample studies that if you do it non-surgically very carefully, they're good at cleaning implants. If you do it surgically, I think it's a huge liability. That being said, I want to show you something very cool here that I didn't have a chance to show yet. There's a new device that we tested, and it's going through FDA now, that I think is going to be the future. And takes, sorry, there's sound coming in there. Let me see if I can reduce it. And takes care of that problem because that's a pressurized water jet. This is the best thing we've ever seen for removing biofilm. It's mechanical non-contact and takes care of that issue of air emphysema because these people have a pattern on pushing water out without any air through a valve in that chairside machine, and it's going through FDA, and it's going to be available next year. And I really think that would be the future for the non-abrasive treatment of peri-implantitis. And we did a dog study, very cool dog study about that. All right.
You want to put your QR code now, or I have a few more questions I think we have time.
Let's do it. And yeah, and this is the QR code, Alan, I talked about. So everybody can get there's a link there to my website. You can download anything you want.
Great. Well, thank you. What are your thoughts about, I think you may have mentioned this, but I'll just make sure you cover it. Complete grinding away of threads and polishing of the exposed surface. And you mentioned airflow, a little bit of decontamination of the surface. Sorry.
Yeah, we're now writing a paper with some of the people that I consider to be, the most influential in the field of peri-implantitis, and it's a very cool paper we're writing for the Europeans, for the EFP. And what we're doing is we have the same case, right? Everybody took a look at the same case independently, and everybody wrote their own evidence-based approach. And out of all the experts, one out of the three is doing exactly what you described, and they have cases where it works. So what I'm saying here is because we have so much information that titanium particles are detrimental for tissue homeostasis. If you have a surgeon that's skilled, that uses the right regenerative protocol, the right biomaterials, excellent technique, and can get results by grinding the implant surface, I will tell you that this same surgeon If they just cleaned it carefully, non-abrasively for biofilm removal, they would get even more outstanding results. This is what the data tells us. And there's one exception to the rule, and that is combined or horizontal defects. If we have a horizontal defect, no bone on the proximal sides where we can graft, and you need to do vertical grafting, which would never work. We have a combination defect of, let's say, 3 threads exposed and the rest of it is an intrabony defect, then you have to manage these exposed threads some way. So if you're intended to do an apically positioned flap, which means that the patient should be okay with the fact that now machined implant or burnished implant will be exposed in the oral environment, you can go ahead and do it. But that means that the patient is now going to be seeing titanium exposed in their mouth.
Right. How do you think Teflon floss would be better for the patient than traditional floss?
Teflon floss than traditional floss. What I recommend is usually none of the two. I mean, yeah, if it's wax floss, I think it's better than non-wax floss, but I usually recommend interdental brushes for people who have implants. And I make sure that when I work with my restorative dentists, they always make sure in the crown design that we could fit an interdental brush in there. It's kind of hard with the way the implants are contoured, right? Usually they're kind of these mushroom-like crowns. It's very hard to educate the patient to find the papillary guidance and go all the way down, because if you think about a molar implant, right? When we have a first molar in the mandible, the diameter in the cervical area is about 10 millimeters. When we remove that tooth and we place an implant, our implant is about 5 millimeters, right? So you have to really try hard to find where the implant surface is and clean it with a floss, versus the interdental brush has way better guidance. And what is impeccable for cleaning implants, we see that it's unsurpassed when it comes to biofilm removal, is water pick. So if I place more than one implant, my patients do get a water pick device.
Thank you. There's 2 questions on what are your thoughts about galvanosurge?
Yeah, GalvaSurge is approved in Canada and I think some places in Europe right now, and it's now owned by Straumann, which is kind of an interesting development. But it's conceptually great because it's a non-abrasive way of cleaning implants. So on a conceptual level, it's very innovative. It's a terrific idea. Practically, I think in order for something to be clinically useful, it has to be easy to implement. The challenge with GalvaSurge is, which pretty much is, you fit it on top of you remove the crown, you fit it on top of the implant, and then there's water with electrolytes creating an electrical current that ditches the bacteria away. Beautiful concept. It takes a minute to put it onto the implant. It's a little bit challenging to implement it in routine practice, so I just don't know what the adaptation is going to be. The water jet, I really like it because it's a chairside unit like the EMS. You just grab the wand, you put it in, you hit the pedal, and you clean it all in 1 minute. So I think for now, this seems to be the most promising way. But if you have a GalvaSurge, if you're able to use it, go ahead and use it. It's 1,000,000 times better than grinding the implant surface.
Right. Last question. We're over an hour. Can the titanium oxide layer be predictably reformed if it's lost through corrosion?
Yeah, that's $1,000,000 question. Somebody's saying the QR code doesn't work. You can plug this into social media like Instagram, Kotsakis DDS, and it's going to be the same thing. Or the website is drdrkotsakis.com. All right, and I can send both to Alan later. So the question here was, can you repeat that, Alan?
Regarding reformation of the titanium oxide layer.
Yeah. That's $1,000,000 question. We're actively working on it in the lab. That's the future. I mean, the future is you get that rusty implant surface that sometimes now looks green or purple, and the oxide is gone, and it's toxic and leaking titanium, and you're able to use solution in the patient that's not going to burn their bone and be able to restore that. So we're actively working on that. It has to do with gradual reoxidization of the surface. There's some leads, and maybe in the next year we'll have something. But right now we know of nothing that can do it, and hydrogen peroxide cannot do it. We really know of nothing that can do it with current technologies.
Great. Well, it's been the fastest hour I've had this week. Thank you so much. Yes, I'll make sure the link's put on the website. I've been having a little technical issues with my move, so if you didn't get the this link earlier for the course evaluation, I'll post that, or you can email me so you get the course evaluation and a CE certificate. George, I want to really thank you from the bottom of my heart. It's been a great hour, a lot of information. I know you have a lot more to share, and I'm looking forward to reading some more of your publications and sharing what you've done for peri-implantitis treatment. Thank you. And everyone, hope to see you next week. Thanks so much. All righty. Have a great evening, everybody. Bye-bye.
Good night.